The next speaker is Professor Valentina Guarneri. The topic will be the biological recharacterization of metastasis in advanced breast cancer.
Thank you very much. I would like to thank the scientific committee for inviting me to this really important meeting. This is the first time that I come here, and I'm really honored to join this such distinguished faculty. So I would like to discuss with you the need of reassess the hormone receptor and HER2 status on metastatic deposits in patients with advanced breast cancer. And the most important thing is that nowadays treatment selection is based mainly on the expression of hormone receptor and HER2. So the biological characterization of breast cancer is the main driver of treatment selection, and this is true in both early and advanced disease. What commonly happens in metastatic disease is that we use the assessment, the biological assessment on the primary tumor to treat metastatic disease, even in cases of metastasis that occur several years after the primary diagnosis. And in the recent years, we have a growing body of literature showing that there is such kind of discordance between the expression of this receptor between primary and matched biopsies. For instance, this is a case series of some retrospective analysis shown here and of two prospective studies regarding, for instance, the expression of the estrogen receptor. You can see that the discordant rate is in the range of 10 to up to 40% of the cases. The same situation is described for HER2. For instance, this is a meta-analysis presented last year in San Antonio. 21 studies, majority of them were retrospective analysis, were meta-analyzed, and you can see here that a change in HER2 expression in both the directions, so in gain of HER2 expression that reached 16%, and also a loss, so tumors that were primarily HER2 positive that became HER2 negative at the time of diagnosis. This is another meta-analysis showing that, again, the discordance rate of HER2, and you can see that the probability of discordance is higher if we look at studies that were focused on the evaluation of metastatic disease rather than nodal disease only. Of course, one of the major concerns is that we are probably there is some error or in the primary tumor or in the metastatic site biopsy analysis. And Professor Cameron clearly reviewed all the potential sources of error, because we know very well that every test is subject to measurement error. And for instance, here we have all the potential sources of variation in, for instance, in HER2 testing, and we already heard before that this is true also for the expression of hormone receptor. So this we might take into account that probably a part of the HER2 change of the HER2 and the hormone receptor change from primary to metastatic deposit can be due to a technical problem, but there is also true that biology is there, because we know very well that tumors are heterogeneous. There can be a genetic drift during tumor progression with the more aggressive clones that are those responsible for establishing metastatic deposit, possibly with a change in the expression of hormone receptor and HER2. And also we have to take in mind that there is the selective pressure of adjuvant treatment that can have an impact on the expression of the receptor in the metastatic disease. So the first question is, does it have prognosis? So we know that there can be a certain variability in the expression of receptor from primary to metastasis, but does it have impact on patient survival? And there are a lot of studies evaluating this point. The first one I would like to show you is a very large retrospective analysis from the Karolinska Institute. We have more than 400 patients tested for ER, more than 400 of patients tested for PR, and more than 100 of patients tested for HER2. The change can occur in both directions, so gain or lose of the receptor, for an overall discordance in the expression of ER of 32%, of more than 40% for progesterone receptor, and around 15% in the expression of HER2. And one of the most important part of this study is that they evaluate this change according to the adjuvant treatment. And very interesting, you can see that the proportion of patients who lose the estrogen receptor expression is highest for patients receiving hormonal therapy or chemotherapy plus hormonal therapy, is lower in the group not receiving chemotherapy alone, and is the lowest in the patients not receiving treatment. So confirming that there is a role of prior therapy in driving this phenotypic change. And there is an important correlation with survival. I would like to point your attention on the blue line, which are the patients with the estrogen receptor positive tumor at primary diagnosis and the estrogen receptor negative tumor at the time of biopsy and on the metastasis. And you can see that the survival is worse in case of overall survival from the time of primary diagnosis, which is shown here, in terms of survival from the time of relapse, which is shown here, and is confirmed if we look at the whole cohort of patients, including distant and locoregional relapse, and is maintained when looking at patients with distant metastasis only. The second very important paper on this topic is this one from the MD Anderson database, where they have looked at the expression of all the three receptors, so considering HER2, estrogen receptor and progesterone receptor, and you can see here a very different outcome for patients with discordant tumor, and in particular the outcome is the worst for patients diagnosis as non-triple negative breast cancer at the time of primary diagnosis, and then who have triple negative breast cancer at the time of recurrence. Of course, this may be due to the inappropriate use of targeted agents in the upfront treatment or after for metastatic disease, but also for the selection of the more aggressive resistant tumors. And this is our database, this is the analysis from our database, where we evaluated approximately 140 patients, and I would like to point your attention to this part, so that we, by performing the biopsy, we excluded the presence of metastasis from breast cancer in 20 cases, where we have a diagnosis of second malignancy, lung cancer, lymphoma, renal cancer, and so on. So these were all patients having breast cancer, suspected to have metastatic breast cancer, but the biopsy of the lesion showed that we were not facing a relapse from breast cancer, but other tumors. The rate of discordance is the same as described in the previous experience, and discordance in single receptor, so the loss of HER2 of hormone receptor, which has the red line, show a significantly worse outcome in terms of post-recurrence survival and in terms of overall survival from the time of primary diagnosis. And by looking at the triple negative receptor concordance or discordance, again you can see discordant cases as those with the worst outcome, and in particular those patients who are discordant and triple negative breast cancer as the worst outcome overall, as shown in the green line. And this is, again, a very important study from the MD Anderson database. This is focused on a patient with HER2-positive disease, and they found an overall discordance in 24% of the cases, but as is acknowledged by the author, they did not retest the primary tumor and the metastasis, so this might account in part for these higher discrepancies compared to the other study, where in the majority of the cases the test has been repeated under the same condition, the receptor from primary tumor and the metastasis. And interestingly, it seems that the HER2 discordance is not influenced by receiving trastuzumab, but by receiving chemotherapy. Again, discordant cases, which is the yellow line, are those with the worst outcome. There are two prospective studies that I will briefly summarize here. The first one is the one from UK, the BRIT study. And I would like to point your attention in the first column, where you can see that we have 205 patients who consented the study, but at the end, approximately 40% of the patients are lost somewhere because of technical problem, refusal to perform the biopsy. So we have 137 patients with tumor accessible from both primary and metastasis. So this is important to consider. The rate of change is slightly lower as compared to the other study, and this may be due to the part that the majority of patients has local relapse, and because they use a different method to assess the estrogen receptor, they use the ORED score. The second prospective study is the Canadian one. Again, 151 patients approached, almost half have the whole the tissue and for the whole assessment, correct assessment of estrogen receptor, progesterone receptor, and HER2. And here we have the rate of discordance, which is more or less in line with the other data. Again, both we can observe gain or loss in the receptor. And this is the only study prospectively assess the survival. And apparently there is no significant differences between concordant and discordant cases, but the follow-up is very short because it's 12 months of observation. And I would like to point your attention that the progression-free survival has been calculated, and overall survival has been calculated from the time to biopsy, which did not correspond to the time of first metastatic disease appearance, because we have patients first, second, third, fourth line of therapy. So this is a population which is too heterogeneous to drive a definitive conclusion. And regarding the follow-up, they did not have fixed examination. So I think we can, this data cannot be considered definitive in this sense. The other point is that if this change in receptor profile from primary to metastatic disease have an impact on patient management. And this is the pooled analysis of the two prospective data I showed you before, showing that approximately 14% of the patients go to a change in the treatment recommendation because of this discrepancy and because of this assessment of receptor in metastatic disease. And to go to the conclusion, I would like to show you two cases from my clinic. The first one is a patient who were diagnosed in October 2006 with immunohistochemistry HER2 FISH amplified 3.3 ratio. At the time of the first relapse, she received chemotherapy and trastuzumab. At the time of the first relapse, immunohistochemistry was 1+, so we decided to go with FISH examination to see if there were confirmed or not the amplification, and we have absolutely no sign of amplification with a ratio of 1.1, and the patients received therapy. She had further progression, and we also collect tissue from further disease progression, confirming the loss of HER2 expression. The second example is a 75 years non-smoking woman who were diagnosed in 2007 with PT2N2 hormone receptor positive HER2 negative breast cancer. She received adjuvant chemo and hormonal therapy and radiation therapy. And immediately after starting hormonal therapy, the CA 15.3 started to rise. We perform a CT scan showing a lung nodule. So we switch her, because of the age, because she already received the chemotherapy, to another hormonal agent with dexamethasone, with careful monitoring on serum markers. And we found also a increase in the CA 19.9. So we decided, because of this unusual clinical course, we decided to perform a biopsy of this lung nodule, and we found a very rare condition, which is a collision tumor between primary squamous cell carcinoma of the lung and metastatic breast carcinoma in the same biopsy. So we treat her for lung cancer. She received surgery and then adjuvant therapy, and she died 4 years later because of progression of breast cancer. If we didn't perform the biopsy, we probably she would have a more rapid disease, and we never have treated her lung cancer. So in summary, a change in hormone receptor and HER2 in both direction, gain or loss, can be documented in 10 to 20% of the patients. And whether this is a true change because of tumor biology that change over time, or because of technical variability, is less relevant. In fact, it seems that the loss of HER2 and estrogen and hormone receptor expression seems to be associated with the worst prognosis. So when safe and easy to perform, the metastasis biopsy should increase the chance of treatment for a relevant proportion of patients, and can even occasionally exclude relapse from breast cancer. Remind that up to 20% of solitary lung nodules are second primaries. And also the NCCN guidelines recommend to perform biopsy, in particular in case of unknown or originally negative estrogen receptor, progesterone receptor, and HER2. There are, of course, some caveats and open questions. One point is to be very careful when looking at bone biopsy, because the decalcification procedure can alter the detection of a hormone receptor. Of course, we have to take in mind the fluctuation around the cutoff. By sure is less relevant for a tumor coming from 15% of estrogen receptor to 5% or to 8%. So we have to take in mind this data. Another relevant point is that if we find the target, this does not automatically result in treatment efficacy. So it is important not to deny a target treatment because of a receptor loss in the metastatic deposit, but also it is important to offer the chance of targeted treatment. For instance, if we see HER2 that become positive in advanced disease. As a matter of fact, however, the biopsy of the metastasis can result in a change of management in a significant proportion of patients. However, if the treatment on the basis of the new assessment of estrogen receptor in the metastatic deposit, if it is correlated with a better outcome, we don't have to now data to support this. Thank you for your attention.
Sorry, we will not take any question. Thank you very much, because we have to go rapidly to next speaker. Next speaker is a movie star of this meeting. He is well known to all of us. He did a